Hi, I'm Dr. Mehboob, and let's talk about your game plan for the NAC OSCE exam. My NAC experience, I would say, was the most enjoyable part of my residency journey so far. It wasn't just about structure or giving the exam. I built friendships that are still going strong. So let's talk about the exam itself. On my exam day, we walked in, we were asked to put our belongings in a plastic bag. The MCC Council website will give you full details about what you can or cannot take in. Now, once you go in, you sign in and they hand you a pink booklet and a pencil, and you enter a hall where the rules and regulations are shown to you. And we are divided into groups, color coded, yellow, pink, green, etc. And the groups have their own route through the stations. Now let's talk about this pink booklet. It's about the size of half an A4 sheet. Literally, if you fold an A4 paper in half, that's the size. Inside, you'll find a few blank pages, one for each station, where you'll write your notes during the 2 minutes at the door. And one of the first pages has a candidate code sticker on it, lots of them. Every time you enter the station, you peel off one sticker and you hand it to the examiner before you begin. The rest of the booklet is yours to scribble on. Use it to organize your thoughts, write down differentials or mnemonics, red flags, whatever works for you as you read the prompt outside the door. Now, everyone goes through the same 12 stations. You can see here you stand in front of a door and you're moving in a rotating circuit, spending approximately 13 minutes in each station. Now, of the 12 stations, two are pilot stations. These are unscored trial stations. You won't know which ones they are, and you won't be told what's inside. They're new and possibly experimental, and they don't count towards your score, which is a relief. Now, on each door, there's a prompt. Now, these stations can fall into two main types: history taking and physical examination, followed by post encounter questions, or a counseling station, which are entirely conversational. So, like I mentioned, on each door you'll find a prompt. For example, 28-year-old Melissa Brown came to the family clinic with concerns of headache for the last 2 weeks. Take a focused history and address her concerns. Now, this station says focused history and address concerns. That's usually a counseling station. If it would have said history and physical examination, that would mean that the examiner would join you and there would be post-encounter questions afterwards. But in this case, it's a full 13-minute conversation with the patient. So now you know that this station involves Melissa Brown presenting with a headache. She's 28 years old. This information helps you get oriented and plan ahead. So now you'll have 2 minutes at the door to organize yourself. During this time, jot down your differentials. For example, causes of headache. Plan the questions you want to ask and anticipate what concerns she might have that you'll need to address. For me, those 2 minutes at the door are everything. This is the time where I mentally organize myself. What am I walking into? What do I expect to be doing in that room? Let's say it's the case for headache. I ask myself, what are the differentials? What are the questions I'm going to ask? What red flags or safety concerns do I need to rule out? This is also the moment where I pause and think outside the box. Is there anything else it could be? Am I missing something subtle? Now, 2 minutes might not sound like a lot, but it's actually enough time if you're structured and organized. In fact, in my prep, I trained myself to write everything I needed in less than a minute, so I'd have extra time to think. And I prepped extensively for these 2 minutes. That's why we call this the 2 minute drill. It was a key part of how I prepped for the NAC. I practiced using a structured template for each station. I folded an A4 sheet and pretend I'm outside a rail station, and in exactly 2 minutes, write down all the essentials. Now, this is what the template looked like. I'd write name and age, presenting complaints, and I'd write a quick reminder to empathize after hearing the patient's complaint. These are early connections that really matter. And for me personally, I use mnemonics. They help me think fast. For example, for the headache case, I use Socrates, site, onset, character, radiation, associated symptoms, time, and severity. And then I added impact because I want to know how this impacts their lives. Now, if the patient is female, I always make sure I ask about her last menstrual period. So I write LMP as a reminder. I also jot down a short list of red flags and differentials to that specific condition. Again, I rely on mnemonics to keep it quick and consistent. With practice, you start memorizing them and then you can scribble them down in seconds. For females, I also add AMGAS. It covers menstrual and gynecological history. And in the case where it has a neuro element, I also add a separate neurological history mnemonic too. For general history, I use Spam Hugs Foss. It sounds like a lot, but because it becomes second nature, I could usually get all this written down in about 30 seconds to a minute, leaving me time to plan out the physical exam if needed. For example, in a headache case, I can plan a full neurological exam. I'm thinking of Kernig's, Berdinsky, Gate, and more, and I want to make sure that I'm not missing out anything serious. And this kind of structure gave me the confidence. So those 2 minutes became my power move going into that station. Now, having this template really helped me prepare for the exam. I did this consistently for over 100 cases, whether it was neuro, gynae, MSK, cardiovascular, or peds. This approach covered almost all bases. This exact approach is what I built into the NAC attack 2-minute drills. It's got two columns. One side, you'll see the exact structure of my template for the 2 minutes outside the station. And the other side, you will find the full breakdown of the mnemonics and sample questions linked to it. If you want to go over this structure, practice it and understand the logic behind the mnemonics, it's all in the NAC attack. You can get a copy of this book online on Amazon. And if you want a free e-version, you can email the address listed below. Now let's get back to what happens once you enter the room. So you hear the first bell. That means the 2 minutes are up and it's time to walk in. Once inside, your 8-minute timer starts. So when you first enter the room, make sure you hand your candidate code sticker to the examiner before you start the interaction with the patient. And now this is your time to take patient's history and, if applicable, perform the physical examination. When the 8-minute mark hits, the bell rings again. And if it's a history and exam station, the examiner will now ask post and counter questions. And this usually goes on for another 3 minutes. And if it is a counseling station, then you won't have examiner questions. You'll simply continue the conversation with the patient for the full time until the final third bell rings. After that third bell rings, that's the official end of the station. That's also your cue to move to the next station and begin reading the prompt at that door. So it's go, 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 right back into the next scenario. Simple, right? But let's be honest, it's not that simple when you're in the middle of it. I completely understand what you're going through, the stress, the anxiety, the constant pressure. It's real. And you're not just trying to pass an exam. You're carrying months, sometimes years of preparation, sacrifice, and dreams on your shoulders, and that weight is heavy. The exam can feel overwhelming. You walk into unfamiliar rooms, interact with strangers, playing patients, and try to hit every medical communication and structural point under tight timed pressure. So you are feeling nervous, stressed, or even scared, and that's completely valid. I want you to know that you're not alone. We've all been there. What you really need to do at this point is breathe, take a deep breath. You prepared hard, you studied, you practiced, you visualized this. It's time to believe in yourself. You got this. Okay? Now, before you walk into that room, remember they already know you're a doctor. You cleared the exams, you've proven your knowledge, but what they're looking for is something more. They want to see the CANMED roles in action. Now, these are roles they want Canada doctors to have. Let's talk about what those are and what they mean in this context. The first role, communicator, they're looking for someone who can truly connect, a good listener, someone who sees nonverbal cues, someone observant, who creates a space for their patients to feel safe, respected, and never judged. And that's what a strong communicator looks like. Collaborator. That is someone who understands medicine is a team sport. You're not working alone. You're part of a circle of care. So whether it's a dietitian, it's a specialist, it's a social worker or nurse, you need to show that you can communicate and collaborate with them all for the benefit of the patient. And that mindset should come through in the way you speak and support the patient. You're always expected to be a leader and a health advocate. Now, that means that you help the patient to understand what's going on with their health. You give them informed consent, you provide clear explanations, and you make them feel empowered to make the best decisions. You identify risky behavior, you gently guide them towards healthier choices with empathy and professionalism. And yes, professionalism is a CANMED role. Now let's talk about how you walk in, because first impressions happen fast. In fact, many assessors form a first impression within the first 20 seconds. So what you wear, how you walk, and how you greet the patient, all of that matters. What should you wear? Start with a big smile. It shows you're approachable, you're confident, and genuinely happy to be there. Your energy sets the tone. Dress professionally, not like a student. You're a doctor, present yourself like one. You should look like someone a patient would feel safe with, someone they can trust. Remember, your attitude matters just as much as your outfit. Your body language speaks volumes, so stand tall, keep your hands visible, and stay open. Avoid slouching, hands in pocket, crossed arms, avoiding eye contact. Instead, use open posture, steady presence, calm energy, and a confident yet caring tone. Let's talk about eye contact. It's one of the most powerful tools you have. Maintaining respectable, calm eye contact shows that the patient that you're engaged, attentive, and trustworthy. When you gaze at the patient with genuine concern and respect, you signal that their story matters. You're not just checking off boxes, you're really listening, and they can feel the difference. Now, there are excellent videos on MCC website that stimulate the experience inside what the station looks like. You'll see examples of how to structure your station, approach the patient, and carry out an encounter. When it comes to history and physical examination, here's a tip. Now, there's no bell separating the history and physical, so train your mind to set a mental 4-minute clock, 4 minutes for history, 4 minutes for physical exam, and that helps you track and ensure that you have time to transition smoothly from one to another. After that, the examiner will ask post-encounter questions, so you will need to leave enough cognitive space to answer those too. Right, so let's talk about your game plan before you even step into the NAC. This is where all your preparation comes together. To be able to read the prompt, write down your structured notes, take a full history and examination and a focused counseling session, and walk out in time, you need a solid game plan. I divided my preparation into 5 segments. Differentials. Now, each morning, I focused on memorizing and understanding my differentials. The goal wasn't just to memorize lists, but to have a conceptual grip on likely diagnosis. For example, if it's a case of hematuria, I had a clear sense of what the most probable causes are. I created mnemonics to help jot them down quickly. You can use picture tools, flowcharts, whatever helps you recall them under pressure. 2-minute drills with study partners. In the afternoon, I would practice cases with study partners. We gave each other prompts and practiced the 2-minute door note in real time. This part is essential, not just for content, but for the mindset. Working with different partners keeps things fresh. It mimicked the real environment where unpredictability is part of the challenge. So you don't want to become too familiar with one style. The familiarity can lower your alertness. The exam stress usually comes from the unknown. So I deliberately exposed myself to a variety of people, styles, and cases, and that mental conditioning is what helped me handle the real thing with calm focus. Physical exams. Now, I dedicated 1 to 2 hours daily to a physical exam practice. I had like a list of 24 core exams, and I tried to cover that at least half of those each day. I practiced each one with 3 minutes to leave enough buffer time if my history ran long or examiners interjected. And even though 4 minutes is ideal, I was aiming for three just to make sure I stayed sharp and flexible. Now, counseling practice is important. I also spend 1 to 2 hours per day on counseling cases. Usually, towards the end of the day, I followed a personal counseling template, which I developed. You're welcome to reach out if you'd like a copy. For each case, I made sure I covered what the condition is, explained the possible causes to the patient, consequences if left untreated, treatment plan, including lifestyles and medication, patient resources, referrals, reassurance, follow-up plan, and any alarm signs to look out for. Now, having a structure helped me stay calm, clear, and focused in real stations. Post-encounter questions and data interpretation was something I spent around 30 minutes daily reviewing. I would look at ECGs, X-rays, lab results, imaging, and clinical scenarios. My goal was to master like a quick pattern recognition and know what investigations and management steps would be for each case. And one of the best things I did for myself, attending the in-person mock exam. Virtual practice is great, but nothing compares to walking into a real room, facing a real patient, and rotating from one door to another. This gave me a real sense of timing, stamina, and mental focus. Boom, 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 station after station. I experienced what it means to stay on for 12 cases straight. I even wore the same outfit I planned to wear in the real exam. This helps me catch any wardrobe issues I never would have considered. And also seeing my study partners in that mock setting also helped me learn from them. The feedback I received was invaluable, and it showed me habits that I didn't know I had. I would recommend doing your mock exam about 2 weeks before your actual NAC OSCE. This gives you time to review the feedback, fine tune your weak areas, and still maintain the energy needed for the final prep. The OSCE Academy offers one of the most complete in-person mock simulations available for IMGs in Ontario. Their setup is fantastic. It's an incredible opportunity to check your readiness, sharpen your skills, and build confidence. This NAC score isn't your final destination, residency is. But your NAC score is a key part of the journey. So don't leave any stone unturned. Take every opportunity, especially an in-person mock. It changed my life, and I truly hope it helps you reach your dreams too. Thank you so much for watching. If you have any questions about this presentation or want resources like counseling templates or drill sheets, please reach out. I'm available on LinkedIn. You can send me a message there. I'd love to support you however I can. All the best to your NAC. Take a breath. You got this.